Thank you very much. It took me 2 minutes to realize I had the UK flag in front of me, not the Indian one, but okay. So thank you very much. I'm going to talk a little bit about the use of continuous glucose monitors across diabetes. So if I can get this to work. So first of all, I think the question is, what is technology? And technology is, simply put, I always say, an enabler. So I'll give you a very good example of this. How many people in the audience remember having to go to the bank to put your money in the bank by hand? Anybody in the audience remember that? Yeah? There's a lot of people in the audience, the younger people, who are sitting there thinking, what does that mean? What do you mean you have, first of all, you have money? Second of all, you put it to somebody else, right? Technology has moved, so we do everything online, right? Again, if you look at all of our habits, let's say, for example, watching movies, you need a really special movie to come out to take you to the movie hall. Otherwise, Netflix, Amazon, it's all technology. So technology has happened everywhere, but when it comes to health, we always struggle to make it part and parcel of our life. It's a quality of life thing, technology, because it makes life simpler. That's as simple as that. It's nothing too complicated. That's what technology is about, and it's about visualization. Anybody in the audience have type 1 diabetes? Okay, you're not allowed to answer this question, so you can put your hand down. Everybody else, think of your most loved one in your life, all right? Could be a mother, father, brother, sister, wife, husband. If you're so inclined, your mother-in-law, could be anybody, okay? Let's say they develop diabetes. Do you want them to prick their fingers or not prick their fingers? Anybody who's going like, you know what, I really want my loved one to prick their fingers. Anybody? And there's your answer about what you would want to do with your loved ones. And that's what technology should be about. Technology should be about enablement of simplicity of life. We've done it to ourselves all the time, right? Automatic cars, cars without drivers. Everything is about making things simpler. So I think that's the sort of narrative we should have around it. And it's all around us, right? It's increasingly, you've got decision support apps, you've got connected pens. It's all designed to do one thing, is make your life simpler. That's all. Nothing too complicated more than that. But when you do that, the main challenge is that people come back and say, is there evidence it works? What do the regulatory bodies say? Is it safe? We just heard about in the last session about GLP-1 analogs coming through, some of them, sure about the quality. Similarly, you will have in the technology world, some that work, some don't work. So you need quality. It's not just about that the cheapest thing works. Those of you who've been to the shops enough will know, just because it's cheap doesn't make it good. It could be just a poor quality thing is why it's cheap. So it's important to recognize that. It's also important the way we see technology. How do we see technology? Do we see it as, oh, just an added bit? Or do we see it as, this is what I want for my loved one, so I'm going to try and get it for everybody who's sitting in front of me as my patient? That's a different outlook. And finally, money is important, because I always say, whenever people say to me, do you think CGM should be available for everybody? There is a very simple answer to that. If it was free, should it? There you go. So the science is not in doubt. It's the money which is in doubt. That's quite straightforward. If all of us believes it should be, if it was free, we should all get it. We believe in the science. What we don't believe in is whether everybody can afford it. That's a different debate. That's an economic debate. And I think that's what is very important to remember. And finally, don't forget the biggest barrier to challenges about our clinicians themselves. Clinicians as clinicians, and that's not because we don't want to help patients. I think the people with type 1 and type 2 should understand that. Some of it is because you're a bit worried about and scared about new things, about learning new things. What is the fundamental difference between us and surgeons? Surgeons are hungry. They're always learning the newest technology. They want to do something new. They want to do something different, because that's how they survive. If you don't do the technology, most recent surgical techniques, you can't survive. Well, in diabetes, you can survive with metformin, sulfonylurea. You can survive with insulin and blood glucose strips. You'll be fine. So it's an important aspect to remember. What about evidence-based? So NICE, I think people need to understand what NICE is. NICE is where we are. And it answers a very simple question. There's a line that we use in the UK. Think like a patient, act like a taxpayer. All right? We are funded by tax. So the basic question is, you think like a patient, you want everybody to have it. Fantastic. Can the taxpayer afford it? That's what NICE tells us. NICE does all the calculations, says yes or no. So for example, recently for GLP-1, they have said, nope, not for everybody, with certain criteria. People are not happy with it, but they have said that's what we can afford if it's tax funded. If you can fund it yourself, please carry on. Anybody can have it. That's what happens in the Middle East. You can afford it, have it. So it's important what has they've said. So in very clear, in type 1 diabetes, very clear. If you have type 1 diabetes, everybody should have a continuous glucose monitor. There's no debate about it. It's affordable. That's the sort of standard line. What about type 2 diabetes is the bigger question. So in type 1 diabetes, just for the record, right now in the UK, 98% of people use CGM. If you've got type 1 diabetes, it is rare, if ever, that people don't have a continuous glucose monitor. It's the basic standard care. And that's because we've worked over the last few years, but that's a sign, that's what we want. Everybody has it. It is funded by the taxpayer. Type 2 diabetes, the evidence base, according to NICE, that's not, so don't mix up that, is there no evidence? No, there is evidence about people beyond the groups I'm going to talk about. The problem is whether it's cost effective and can be funded by the taxpayer. All right, so those of you come from different states in India, so I'm doing lots of work in India right now. It's a very federal model, isn't it? Different states are different. And if you're going to go to a state government and say, I want you to fund it by the tax, for the tax that you get, you need to justify that, right? Because governments have got so many other things to invest in. So that's type 2 diabetes, and they've said certain areas, and doesn't come out very well. It basically says people who are on insulin. If you have it, what about people who are taking tablets? What about people who are on diet control? What about people who are pre-diabetes? That's the sort of debate that goes on all the time. So there's some data around basal insulin, and this is what is based on why NICE is approved. This is basal insulin. You can see the impact of CGM. No question, makes a difference, does help. That's why we want to have, for people with insulin to have it. What about current guideline recommendations? Pretty much across the board, it is there. ADA says, but don't forget, what is the difference between ADA and NICE? ADA is an organization which makes recommendation based on the evidence, not the money. Different, right? Compared to NICE, which is saying, yes, the evidence, but does it fit? Okay? So, what is the proposed use of CGM throughout the natural history of type 2 diabetes? There's a really good one. It basically says, so will it work with people who have got type 2 diabetes or pre-diabetes in the early stage if you give them CGM intermittently and said, do you want to change your habits? Do you want to see what that extra chapati at night does? Do you want to see what a kulfi does? Should you have 2 kulfis every night? Maybe you need to relax a bit. It's about education, right? Problem, evidence base. So I always said in every meeting, to every company, please give us the evidence base so we can give it to people. Leaving it to us and then saying, can you afford it, is not helping anybody going forward. So, this is a really good paper on continuous glucose monitoring for the routine care of type 2 diabetes. I think I always ask people to think about it from a quality of life. Doesn't matter what you got. Take a step back. Would you want to prick your fingers? No, you wouldn't. So, does the science support it? Will it work if it's intermittent? And people recently I was doing a debate where they said everybody with type 2 diabetes should get a CGM. And I said, this was in the UK. So I asked the question in the audience. I said, who's got a sports car? Who's got a sports car in this audience? Anybody own a sports car? You must do. Anybody? No? You own a sports car? Okay. Wonderful. Only person. Who would like to have a sports car? Why didn't you have a sports car? What stops you from having a sports car? You got other priorities where you need to put your money, right? House, mortgage, kids, dogs, whatever, right? Valentine's Day present, priorities, yeah? So here is the problem that you have in type 2 diabetes. In type 1 diabetes, it's quite straightforward. I want insulin, I want continuous glucose monitors, and I want to get them to a hybrid closed loop system if you can afford it, right? That's pretty straightforward. There's nothing else. Type 2 diabetes, you've got one pot. What do you want? Remission, SGLT2 to reduce your renal outcomes, a GLP-1 to reduce your cardiovascular outcomes, or a CGM. You got one pot. You see? And I think that's where you need to think about it. If it was my mum, and I can afford only one, what am I going to get her? That's the question the governments are asking every day, right? Because they are trying to do it for your mum, or your son, or your child. And thereby, it then becomes about, can you afford it? Goes back to the sports car thing. Of course I can, because I can pay the rest, and now I will have a sports car. That's the problem with CGM in the space beyond insulin at the present moment. competing interests make it harder for the individual to sit down and decide which one to go for. So I like everybody to remember is that NICE works on a cost-effective model. So people can criticize NICE, but that's why we are a different tax-funded system. Okay? I pay my tax, as a result of which population benefits from it. Think like a patient, act like a taxpayer is a fundamental thing we all, and I encourage everybody, it doesn't matter what your working system is, you're doctors, right? You all should think about it. Can my patient afford this? What can I do to make it affordable? Can I use it as an intermittent device? Those are the things. And it's an important thing to remember. Also, the challenge for type 2 diabetes, as I said, is that, and I think this crystallizes the problem of CGM. If CGM was cheap, everybody would have got it. The problem is it's not cheap. And I don't criticize any industry for it, because the industry also needs to make the profit to go and do research so they can create more devices for you. Right? So we're caught in between. So what we need to do is get more evidence to say, where would it work in the pre-diabetes stage? Would it help if we combine it with dietary advice, along with intermittent use to give them advice about the types of food you need to have, what impact carbs has, what time of the day, and change their behavior? Then yes, you could probably make a case. So also, there's a bigger, does anybody know what is the best diet? What's the best diet in the world? Anybody? After all of you have had your fantastic lunch provided by Diabetes India? Riddhi? Jazz? So Jazz has gone back to the sports car model of the one you can afford, right? Which is very important, right? There's also one more other thing. Who's tried a diet? Who's tried it? Come on, guys, you've all tried diets at one stage. Some marriage party to go to, some big occasion. Everybody wants to look a little bit slimmer, right? Anybody want to sort of go up and say? The best diet is the one also is about which you can sustain. How many of you have tried a diet after 3 days go like, you know what, this is really difficult. I really, really fancy something now different. That's the problem with diets. We've got a national diabetes prevention program, right? The best in the planet. Have you heard about it? Type 2 Diabetes Prevent UK. Do you want to know how many people have sustained it after 5 years? 7%. All of you have tried it, will know exactly why, right? I've tried a diet, useless. Absolute waste of time, right? Because it needs phenomenal mental strength. It needs phenomenal dedication. So people who do it, people will come to you and say, I see nowadays some soap star saying he's lost all his weight and is looking very trim. Somebody called Ram something. Ram Charan, Ram Kumar, Ram Kapoor. He was like quite overweight and now he's working around showing his muscles and looking quite trim. He claims he's not using Zultafy and all that sort of stuff and all that, Manjaro. But whatever he's doing, it's working for him. And if it's diet, he's obviously putting a lot of effort, right? And obesity experts will tell you about the way the brain resets back and how weight comes back. So that's another thing altogether. But here's the thing, I'll finish with the last few things. It's a change in behavior. It's a quality of life thing. It's a change of behavior. It's an evidence-based look at cost and comparison are very important as you're going forward. And I think that's a sort of important bit to remember about how type 2 diabetes and CGM should work. So in summary, CGM and type 1 diabetes should be basic standard care, full stop. I don't think there should be any debate about this. The question is about affordability of different countries. And as I always say, there are two countries. This country has got two countries. Do you know this? One is called India, the other is called Bharat. Correct? India goes to multiplexes, can afford a lot of things, every single thing in the planet. Bharat is struggling to make sure they have got insulin fridges for kids with insulin. Correct? That's the gap we're trying to close. That's the majority of the country that is there. We all know this, right? We all would like to do better if the person in front of us could afford it. That's our challenge. It's basic type 2 diabetes. There's cost-effective model for certain cases. As I said, with insulin, the potential is high in all cases, but there's a competing interest across the board. In pre-diabetes, you can bring in behavioral change. It is a quality of life metric. You all would want it for your loved one. And there's progression of science and inevitable. So it will happen. It will happen. Most people are struggling with it. It's like those of you will remember about having to dip the urine to check the glucose. We then move to glucose finger pricking. We're going to move to non-invasive one. It is inevitable. It's a question of when it happens. So I'll finish there. 6 seconds in hand. So thank you very much for listening.